Immune checkpoint inhibitors play an important role now in the treatment of breast cancer. At this point in time, they're standard of care for patients with metastatic triple-negative breast cancer in the first-line setting, provided the tumors are PD-L1 positive. And we also expect this to be standard of care in patients with stage 2 or stage 3 triple-negative breast cancer based on the recent result of the KEYNOTE-522 trial. It is interesting, there's a difference in terms of who benefits from this between the metastatic setting and the early disease setting. In metastatic setting, it seems to be patients with PD-L1 positive tumors, which is roughly about 40% of patients with triple-negative disease, defined by the SP142 assay with a cutoff of 1%, or the CPS2-C3 assay with a cutoff of 10. In the neoadjuvant, in the early disease setting, we did not observe this. We saw a benefit regardless of PD-L1 expression, similar benefit in patients who are PD-L1 positive or PD-L1 negative with the addition of immune checkpoint inhibitors to neoadjuvant chemotherapy. We're now further expanding the immune therapy program into other subtypes. Very interesting early data, for example, in HER2 positive disease, but also in ER positive disease, and neoadjuvant and trials in the metastatic setting are ongoing, looking at combination strategies for predominantly chemotherapy, but also other compounds and immune checkpoint inhibitors. I personally believe there's also a role for checkpoint inhibitors outside the triple-negative breast cancer. We will have to define that group of patients who have usually inflamed tumor types and benefit from the addition of checkpoint inhibitor therapy.